Well, thank you very much, Anita, for a typically warm and generous introduction. It's a great pleasure to be here. When I became Health Secretary, quite a lot of people said to me it is the most difficult job in government. I've actually concluded it's the most secure job in government because there isn't a single other politician who actually wants it. But I have, as I said when I took on the job, found it to be the biggest privilege of my life to do this job. And I would like to start by paying tribute to someone else who has one of the most difficult jobs in the country, and that's Simon Stevens, who has just started NHS England. And I think we've seen in the last 3 months Simon's leadership, his insights, his vision is something that is going to bring huge value to the NHS. And I know everyone here wishes Simon well in what is another of the great challenging jobs in the health world. I'd also like to thank all of you, because in a period when we've been thinking a lot about safety and how to improve it in our hospitals, you have done one of the most risky and dangerous things possible, which is allowed me loose on your wards week in, week out. And as you know, not coming from a clinical background, I try to go out every week somewhere different in the NHS. I've taken blood pressures in Guildford, I've dressed wounds in Leeds, I cleaned commodes in Harrogate. It's funny what nurses can think of to give you when they know the Health Secretary is working for you for the afternoon. A couple of weeks ago, I shaved a man in Lincoln Hospital, very brave man indeed. So if you see anyone walking around Lincoln with half a moustache, that's probably the Health Secretary. But what you find when you go out onto the front line is that people are working very, very hard. This is a system that is running hot. And I think some of the numbers demonstrate that in really quite a startling way. So if you look at the budget that we've had in the NHS, over the last 4 years, it's gone up by a little, but essentially, in real terms, it's remained broadly flat. And then you look at the activity that we have increased over those 4 years. So these are figures for the increase in activity every single day. Every single day in the NHS compared to 4 years ago, we are referring 1,000 more people for suspected cancers. We are carrying 1,000 more people in emergency ambulance journeys. We're conducting 2,000 more operations. We're seeing 3,000 more people in our A&E departments. We're giving 6,000 more GP appointments, 10,000 more diagnostic tests, 17,000 more outpatient appointments. Now, that was a bit of a memory feat. Can I just tell you it again, though, because I do think it is pretty impressive. 1,000 more cancer referrals, 1,000 more emergency ambulance journeys, 2,000 more operations, 3,000 more A&E attendances, 6,000 more GP appointments, 10,000 more diagnostic tests, 17,000 more outpatient appointments. And that is happening because people on the front line are working extremely hard. And I would like to start off by thanking you, but also by asking you to thank all the people who work in your organisations for their hard work that's making that possible. And I'd also like to ask you to thank them for something else, which is the extraordinary response that we've had throughout the NHS to the Francis report. We have 5,000 more nurses in our wards over the period of just a year. We're turning around 15 failing hospitals. We've made a huge number of changes, and that is because the NHS collectively has done a rather wonderful thing. They've looked at what happened at mid-staffs. They haven't said, this is nothing to do with me. They've said, actually, we've seen bits of that happening in our organisation and we want to stamp it out because that's not what the NHS is about, and that makes me incredibly proud. So I'd like to thank you for that. And what shall I talk about this afternoon? Well, when I became Culture Secretary, someone in the arts world said, all we want from a minister is two things, money and silence. And I'm beginning to think the health world may not be that different in this respect. I want to talk, though, about the sustainability of the NHS. Because when you have a system that is under such pressure, of course, that's a question people ask. And I think the first thing we have to recognize is that if it's running hot now, it's going to run even hotter going forward. If you look at the changes in population, by 2020, we'll have an extra 1.3 million people over 70. If we do nothing, we'll need to do another 2 million operations every year, potentially another 16 million GP appointments every year. That is a huge amount of additional pressure. And my answer to the question as to whether the NHS can be sustainable, whether it can be sustainable and true to the values that make us all so committed to the NHS, a service free at the point of use to everyone, no matter who they are, rich or poor, young or old, city or country. That's what the NHS is all about. My answer is yes, it can be sustainable. It can be sustainable, but if and only if we are bold in continuing to make real progress in some significant areas of reform. And I just want to touch on two of those this afternoon. The first relates to something that I've already talked about, which is Francis. If the NHS is going to be sustainable, there must be no turning back the clock on Francis. Now, why do I link Francis to sustainability? It's because unsafe care is one of the most expensive things that you can possibly do. It's probably the single biggest waste of resources in our NHS today. Of our precious NHS budget, I have to spend £1.3 billion every year, not on frontline staff, but on litigation claims. Other studies have said that the cost of adverse events in the NHS is around 800 million every year. And if you just take one, which is hospital-acquired UTIs, cost of that around £69 million every single year. And the truth is that we have come a long way, but we have a lot further to go. Today's story about the tragic blood poisoning of 18 children shows that we can never take safety for granted. It also shows the importance of prompt and early identification of problems. But if you step back more broadly and look at our record on safety, case note reviews suggest that 5% of all hospital deaths are avoidable. That's around 12,500 avoidable deaths every year. That's the equivalent to a jumbo jet crashing out of the sky once a fortnight. If you look at never events, last spring, at one of our major teaching hospitals, we removed someone's fallopian tube instead of their appendix. Last summer, we amputated the wrong toes off someone. This spring, we gave the wrong man a vasectomy. And these are things that should never be happening in our NHS. I don't point the finger at the NHS as compared to other healthcare systems. I've just been in America this week, and they have the same issue, and I think they have the same issues in other European countries as well. But there is a lot more to do. And I think we have made a start. And I think, in particular, I'd like to pay tribute to the terrific start made by Mike Richards, the new Chief Inspector of Hospitals, Steve Field, the Chief Inspector of General Practice, and Andrea Sutcliffe, the Chief Inspector of Adult Social Care. And we now have the most rigorous, transparent inspection system of any country anywhere in the world. And that's a terrific start. But in the end, if we're going to make this change, it's about culture. And culture change has to come from inside. And because you are NHS leaders, we are NHS leaders, I just want to talk about two particular aspects of culture change that I think really matter. We've got to make it easier for doctors, nurses, and frontline staff to speak out when they feel there's something wrong, when they think there's a risk to patient safety. All the evidence from other industries that have managed to improve their safety record, like the airline industry, is that it's about encouraging a culture of openness, transparency, and learning. And I was earlier this week in Virginia Mason Hospital in Seattle. Virginia Mason is the Salford Royal of America. It is the safest hospital in America, just as David Dalton has done such an extraordinary job here. And incidentally, their journey to becoming a global beacon of excellence for safety started with a tragedy in 1994 when they killed a woman by injecting antiseptic fluid into her brain. And that really started a huge push. But I just want to show you a slide here that I think illustrates the impact of what happens when you create a transparent culture. So when I went to them, they said to me that they were incredibly proud because for the first time ever, in 1 month, just 1 month, they had had 800 staff-raised safety concerns. 800 concerns. This is actually only a 330-bed hospital. And they call them PSAs, patient safety alerts. And you can see how the number of PSAs has risen over the years. That's the red bar. Now, the blue bar is their reported claims, their litigation claims. And over the same period, that's gone down by 75%, 3/4 drop. And that's because they've created a culture of listening to staff. Now, I went to Basildon Hospital, one of the 15 hospitals in special measures. And one of the things that really struck me, I spoke to a nurse in one of the pediatric wards where they had particular problems. I said, what's changed since you've gone into special measures? She said, it's very simple. Before, when we had a problem, they weren't interested. Now they listen. And that's really what this is all about. So creating that culture of openness and transparency. And yes, we've got to do better with whistleblowers. But actually, if it's about whistleblowing, we failed, because whistleblowers are really people who feel that their trust hasn't listened to them. And so it's really about that culture. And I know you're going to hear from Helene Donnelly after me, who will have some real insights in that respect. But a second culture change, we've got to be much bolder and braver in our use of transparency and data to improve performance. Now, I think many people here will know the story of Bruce Keogh and Ben Bridgewater back in 1994 setting up the National Adult Cardiac Surgical Database, which was a pioneering program to publish the outcome rates for heart surgeons. Let me just show you the impact of that program. So the green line is what you would expect mortality to have increased by on the basis of an aging population. The red line is what actually happened to mortality over that period. So the purple bars is an estimation of the number of lives saved as a result of that transparency. And that is something which I think holds lessons for politicians as well, because I think in an era of transparency and peer pressure is a far better way to improve standards than Stalinism and top-down targets. And we need to reflect on that. But the most important thing about data transparency, because from this autumn, the NHS will be the first country in the world where you can see surgery outcome data for 13 different specialties, is that it puts patients in the driving seat. It gives patients control of their own health destiny. And that's something that in a patient-centered system, we should all be very keen to embrace. So, no turning back on Francis. But there's a second really important reform, which I think is potentially even more important for the long-term sustainability of the NHS. And that is to make sure that we revolutionize out-of-hospital care. And this is something which I don't think there's any disagreement on the theory behind. I think everyone will say that prevention is better than cure, we need to be better at looking after people at home, that this could save the NHS huge amounts of money, and I don't think there's any disagreement from trusts to GPs, to community foundation trusts, and so on. But I think there is understandably a lot of skepticism about ever actually making the change that we need to make. And I want to suggest to you that in the last year, we've made 3 very significant changes, which I think are putting us well on our way to making this happen. And the first of those is the introduction in the new GP contract from April of named GPs for everyone over the age of 75. It is absolutely essential that we have an out-of-hospital care system where we know where the buck stops. And in most cases, that will be the GP. Not in all cases, but in most cases. And by reintroducing that accountability, What we want to do is a system whereby when someone's discharged from a hospital, you have a handover that's every bit as professional from secondary care to primary care as it would be between the wards in a hospital or between the shifts in a hospital. And within that change in the GP contract is something else. It's not just named GPs for all over 75s. It's the responsibility for proactive care for their most vulnerable 2% of patients. And I think over very many years in the NHS, we have undervalued general practice and made it difficult for them to deliver the proactive care that we need them to deliver. And this is intended to be a very profound change to start addressing that issue. So the GP contract, we've started to make some important changes. But there's a second change we've had this year, which is the Better Care Fund and the Better Care Programme. And this is a very ambitious £4 billion merger of the health and social care systems. It's a large sum of money, but in order to access it, local authorities and local NHS organisations have got to break down barriers that have existed for years in order to deliver proper joined-up care. So they have to commit to joint commissioning of out-of-hospital care for people in the social care system. They have to commit to record sharing, electronic record sharing for the first time so that everyone knows what everyone else is up to. They have to commit to 7-day working, which is a particular bugbear for a number of hospitals. This is a very big change. It's starting from next April. It's going to take time to get there, but it's a very profound and important change. And one thing I would say is that any out-of-hospital organisation that is benefiting from extra resources as a result of the Better Care Fund on the basis that they are going to reduce emergency admissions in our hospitals must share some of the risk if what they do doesn't, in fact, reduce emergency admissions in hospitals. And so by making sure we have a proper risk-sharing profile in all the Better Care plans, what we will do is make sure that incentives are properly aligned and that everyone is trying to do the same thing. So that's the second important change. And then the third one is something that Simon Stevens announced a couple of months ago, which hasn't had huge publicity, but I think in a way will be even more profound than any of the other things that we've talked about. And that is the invitation to CCGs to jointly commission NHS primary care with NHS England. This is probably the first step in turning CCGs into accountable care organisations, because you will have one organisation responsible for commissioning secondary care, co-commissioning primary care, co-commissioning social care through the Better Care Fund. And that gives a huge opportunity for capitation funding, for all the things that potentially could lead to that real revolution in out-of-hospital care. So very, very ambitious programs happening. And just to return to Anita's point, these are things we don't need to talk about in the Queen's speech. These are things we need to deliver on the ground. And I would much rather that everyone in the NHS is actually thinking about how we're going to make all these programs work than concentrating on new legislation that's being passed in Parliament. And that's very much the focus of government activity. Let me just finish by saying that, despite the huge pressure that everyone's under, I remain very optimistic that the NHS is up for this challenge, that the people in this room are up for this challenge. And the reason I'm optimistic is, first of all, you go around the world, all healthcare systems are facing the same kinds of challenges that we face. But the NHS has some unique advantages. We have the advantage of long traditions of primary care. We are one of the few countries where the first place people think of going when they're not well is a GP. In many countries, it's a hospital. And we are seeing innovation coming back into primary care with some extraordinary work by CCGs in Bath, in preventing avoidable admissions, in Tower Hamlets, in raising the professional standards of GPs, in Northamptonshire in terms of falls prevention. There's some really exciting things that we are beginning now to see in terms of primary care, and energy and entrepreneurialism in CCGs, which is having a big impact. The second thing is we have a tradition of innovation in the NHS. which will be our great ally in making these changes. When I was in America, I reminded them that we are second only to America in the number of Nobel Prizes for medicine and science, second only to America in the number of top 100 medicines developed. We are one of the top 4 countries in the world in the use of electronic health records in primary care, one of the top countries in Europe in the use of picture scanning and imaging systems in hospitals. We have a lot of traditions of innovation. And when you look at not just the innovative work that Salford is doing on safety, but you look at the dementia work that Guy's and Tommy's are doing, you look at the PASS system in UHB, you can see some extraordinary innovation that's happening inside our NHS. And we need to make sure, as a government, that we support that innovation and don't get in the way of it by being too heavy-handed. And the final point I'd make is that we have another asset. And that's one that we should never forget, perhaps the most important asset of all, and that is the dedication, the commitment, and the values of 1.3 million NHS staff. And I see this every single day. But just to give you one recent story of an A&E doctor, a young A&E doctor, who told me that she had been a bit unprofessional, she said, the previous week, because she's actually cried at work in front of patients because she'd seen a 90-year-old man say goodbye to his wife of over 50 years. And I think we just have so many people who are committed to patients, who put patients first, who have those values. And if we get behind them, if we allow them to have their voice, if we bring out the best in them, then that's our best weapon of all. And I'm absolutely convinced the NHS will go on from strength to strength, even despite the extraordinary challenges that we now face. Thank you very much.
Thank you very much indeed. Well, do you know, the first time we met, do you remember where that was?
I certainly do.
Yeah, it
wasn't my moment of glory, I have to say, Anita.
I'll share it with the class while you raise the lights and the paddle people make their way into the audience. Sometimes in an editorial meeting, particularly at the BBC, someone will have a brilliant idea about party conference. And the idea one year was, in the year that you got in, actually, 2005, was that I should co-present with a newbie. It seemed to be kind of actually a poison chalice for most of the people who took part. But one lost her position in the shadow cabinet. I won't name her. The other one was Linda Opick. And the third was Jeremy Hunt.
Became Health Secretary.
Became Health Secretary. So make of that what you will. Could you please put your hand up really high, like a question, and then if people with the paddles could go and then just stand, because the lights are very difficult to see. There's a lady, number 2, waving like crazy to pass over the microphone. Just while we get there, you started today, Jeremy, by paying tribute to the people on the front line, and you would have passed the demonstration outside from people who say, look, don't pay us tribute, pay us the 1% that was promised to us by the pay review body. What do you say to those people?
Well, I would love to have honoured what the pay review body recommended in full, but I have a responsibility to patients as well, and the truth is that we have very, very constrained finances in the NHS. What we are doing is we're giving everyone a minimum of 1% pay rise, but I couldn't afford to give a 1% on top of additional rises coming through increments that people were getting, because the very clear advice I had was that if I did that, trusts would end up laying off around 6,000, potentially 10,000 frontline staff. And having just come through Francis, and having just started to make sure that we crack this issue of proper levels of staffing throughout wards, I just had to take, I'm afraid, a very difficult decision to do what I thought was the right thing in very constrained financial circumstances.
Okay, I think we have got mics to people now. Number 3, first of all. Thank you.
Yes, good afternoon. I'm Chris Butler, Chief Executive of Leeds and York Partnership NHS Foundation Trust. A brief reflection and a question, if I may. My reflection is that where out-of-hospital care is concerned, there's been a revolution in out-of-hospital care over many years in mental health and learning disability services. And so I would invite you and other colleagues to actually reflect on the lessons that we've learned and the things that people could actually do in imitation of the work that we're doing. My question relates to issues of parity of esteem vis-à-vis mental health services. And I was just wondering if you could offer us a couple of observations related to what your particular priorities for parity of esteem would be.
Very much so. And, you know, thank you for bringing it up. And I do think that in mental health and learning disabilities, we've made some very impressive progress over the last 25 years. I think parity of esteem probably means making tangible progress in 3 areas. The first is towards a waiting time standard. I think one of the reasons that money has been sucked out of mental health into physical health has been because you've got a waiting times target in physical health. We haven't had it in mental health, so when there's pressure, inevitably the money follows where the targets are. Secondly, I think we need to look at whether we need, as we talked about named GPs for the over 75s, whether we need better clinical accountability, a named accountable clinician for certainly people with severe mental health needs, and I think that could make a difference. I know that we introduced new ways of working in 2007, I think it was because of a shortage of psychiatrists. But I think we have learnt that it doesn't work if you blur the lines of responsibility and accountability between doctor and patient, and I wonder if that's happened too much. And thirdly, I think we need to do much better at early intervention, particularly for children and adolescents. So those are the 3 areas where I think, probably be top of my list.
If you have a mic, please do stand up so that we know where you are. Yes, the lady over there.
Hi, my name's Asha Pillai. I'm a GP and a locality clinical director for Northwest Surrey CCG. I've got a couple of points. One, you said the Better Care Fund was extra resources. It's not extra resources, it's repatriated resources. And how are we going to look after all these extra patients that we're having to see with repatriated resources taken from one area and then put onto another area? That's number one. Number two, you said in one of your points there that there's going to be approximately 16 million extra GP appointments in the next number of years. Where is the resources for this? At the moment, general practice sees about 80% of patients for less than 8% of the NHS budget. So if you could clarify that, I'd be grateful. Thank you.
Okay. Well, I've been an NHS patient all my life, but new to the NHS from a leadership point of view. And the thing that I'm told most frequently, whether it's by GPs or by hospitals or by an A&E department or by voluntary organisations, is that we waste so much money because we don't look after people proactively at home. And we need to be better at doing that. So the Better Care Fund is an opportunity to put resources into that. But it has to be done on the basis that it really does reduce activity in emergency departments. And that's why it's important that we have the risk sharing. If we're going to be spending less in one part of the economy, then we need to actually know that we're going to have results. And that's why I think risk sharing is a very important part of the Better Care package. I think we do need more GPs. We've announced plans to train 5,000 more GPs. But we also need to look at more innovative ways to reduce the pressure on GPs. I think at the moment, many GPs feel like they're in a hamster wheel. They're seeing 30 to 40 patients a day, 10-minute appointments. They're absolutely exhausted by the end of the day. And there are other models. One of the potential advantages of moving to online consultations, which is now being adopted by 1,100 of the 8,000 practices, is that it means that you can take a shorter amount of time with people who have more minor problems. There's also very big advantages to patients. But we need to look at these new ways of working. And the NHS resources are set until the end of 15-16. That's really been agreed across the political spectrum. But we'll have to have a debate beyond that time as to how we fund the increasing pressures that we need from an ageing population. But I will say this, it's much easier to make the argument for extra funding if we really have been innovative and done everything we possibly can to eliminate waste in every part of the system. And that's why I think it's so important that we think about that as well.
Were there any questions on this side? If not, we'll go to the lady here at the front, I believe. Who's got the microphone here? Yeah.
Hello. Deborah Harris. I'm a non-executive director of Moorfields Eye Hospital. Just hoping if you could expand a bit more on the innovation, specifically around things like disruptive innovation. The previous question, you responded and you spoke about different ways of working using mHealth. But I was wondering if you could expand on some of the things that Simon Stevens said earlier about the use of technology. You mentioned open data, working in different ways, and how through your leadership, you will help the NHS to adopt an approach where you can skunk works, where you can put your head above the parapet and do things differently and not find it to be a career-limiting career-limiting risk. So actually being able to fail fast and fail forward, because I think that's the approach that our cousins across the pond have, which means that they are probably ahead of us in some of the innovation that they do. We have the knowledge here, but often we have the brain drain because people are too scared to do that. So from your leadership perspective, how you would invest in technology to help us be better and not just technology for technology itself. We don't want another NP unfit.
Well, first of all, can I thank you because you allowed me to come onto the front line and do a part of a shift in your children's hospital at Moorfields. And actually, I saw a really innovative example of the use of technology there. My job for the morning was to conduct the friends and family test on children, which you might think is quite a difficult thing to do, but actually I went round with an iPad and there was a brilliant cartoon which engaged these children and actually managed to wheedle out of them whether they enjoyed and responded and felt looked after by the service they were receiving from Moorfields. But I think your question is profoundly right. I really do, because I think we do have a culture, not just in the NHS, but in this country, where it's too difficult to fail. My background is setting up and running my own business for 14 years, and believe you me, I had a lot of failures. I always remember Churchill said, success is the ability to go from failure to failure without losing your enthusiasm. And that's quite a good motto for leadership in general, but we do need to create that culture. But I actually am quite an optimist because I think they do have a great culture of innovation in the US. They need it. They've got some real problems in their healthcare system. They look at us with great envy at the fact that, they've got 45 million uninsured in the US. But I think that use of technology, I would say we can use technology. The chart I showed earlier about heart surgery outcome rates, I think actually collecting and publishing data without any financial incentives attached to it at all is a much better way of improving performance. People are proud of what they do and they don't want to do a bad job. And if you just show them the information as to how they're doing against their peers, you get dramatic behavior change without really any top-down effort. I think that's one very big area. I think the other area where I think we can do a lot better is in terms of improving access to the NHS. So, we think of technology as being very popular for someone who is, for example, at work and doesn't want to take off time for a GP appointment, and they might be able to, if it's a minor concern, do an online consultation. But also for people who have mobility problems, to be able to talk to a GP or a nurse in a hospital, as happens in Airedale Hospital at the moment. They have red buttons that they give to older people that they just, as long as their TV is on, they can press the red button and they're talking to a nurse within a few seconds. There's some brilliant innovation that we need to adopt. But I think the lesson that I take, the great temptation in my job, you see something amazing. So I'll tell you my latest thing that I'm really enthusiastic about, just to give you an example of this. Why can't GPs Skype consultants? Why can't you go to your GP, you've got a scab and you're not sure if it's a cancer or not, and the GP's not sure either. Before they make the referral, why couldn't they have a quick conversation with a consultant over Skype, potentially avoiding that referral, helping the GP to learn more about the issue? I think the worst thing I could possibly do, having got enthusiastic about that, is to try and insert it into the GP contract and force 8,300 practices to do that. Because then they'd be doing it to please me, not because they wanted to make it work themselves. And so I think it's about freeing up the system to allow people to put their head above the parapet and not coming down too heavily if they fail.
I think, sadly, I know there are a lot of you who would like to ask questions, but we just do have time for one more question. And I'm being sort of front of hall heavy, I'm afraid, because I can see you. So yes, please.
Thank you very much. I'm Heather Strawbridge. I'm Chairman of South Western Ambulance Service NHS Foundation Trust, and I apologise, I asked you this question when you were first appointed as Secretary of State, but
I obviously haven't answered it then.
The issue continues. And it is there any further support that you can give to service-wide integration, particularly in the urgent and emergency care services, especially for ambulance services and their natural role of running 111 services?
Well, I agree with you, actually. I think there's a very natural role for ambulance services running 111 services, and I think that's a form of integration that I would welcome seeing more of. I think there is huge potential for doing things like allowing ambulance drivers, paramedics to access electronic health records on their way to visit a patient so they can see if someone's a diabetic, what their allergies are, what their medication history is. There's huge potential for treating people on the spot rather than taking them to hospital, which I think around half the ambulance services in the country are doing in a meaningful way, but around half aren't. And I would have thought in somewhere, you may be already doing this, but in Devon and Cornwall, where you've got long, windy country roads, that's a very attractive thing to do. So I think there's huge potential for that integration. And I think, so I would say really it's about embracing the potential of the technology revolution is the best way of delivering that kind of integration.
That is unfortunately all we have time for. Please do, though, join me in thanking the Secretary of State for Health, Mr. Jeremy Hunt.